we have Dr. Neelima Mehrotra for her talk. She is the head of the ophthalmology department at SRMS Medical College, Bareilly, and also the head of the eye bank over there. And I think ma'am is also heading the UP chapter of the WAS. Over to you, ma'am, for your talk. She'll be speaking on the IOL, choosing the right IOL. You can start sharing your screen.
Thank you, Dr. Maya, and I will be sharing my screen now. Is it visible and am I audible?
Yes, yes, ma'am, go ahead.
Right. All right, good afternoon, and I'm really enjoying this WAS session here. Thanks a lot to all of WAS and Dr. Mohita and AIOC for having me here. And the topic I'm going to talk on today is choosing the right IOL, which will win you your patient over for life. This is one of the things we all are commonly doing in our routine practice. So I picked up this line, which really makes sense to us, is if we consider surgical technique and our surgical skill as the art, which ensures that cataract procedures go smoothly and give us great visual results, then IOLs are the science. So when we are talking about what IOLs to choose, these are few of the things which we must talk about to our patients, because the price is a consideration, reading glasses, whether the patient is happy to use or not, astigmatism, again, toric lenses, the desire of patient to be spectacle free, the patient's visual needs, the condition of the other eye, other ocular pathologies, any previous surgeries, and any lack of zonular or capsular support during or before surgery, and whatever occupational requirements or patient's desires for vision need. So this is the Ridley lens at the top for you. So the question today is, should we be traditional cataract surgeons or should we be refractive cataract surgeons? If we are not refractive cataract surgeons, it might be just that we do not want to, but otherwise in the market, we have so many premium lenses and so many options for post-op refractive procedures. So why we go in for all these lenses is because we want our patients to be more and more satisfied with the post-operative visual results. Why we don't use these lenses is also because we know our patients get really dissatisfied, which may be because of over expectations at some times, or maybe because of uncorrected visual acuity not being 6x6 or 20x20. So we must not only think of the most premium lenses to use, but also think of enhancing post-operative visual acuity, because that is what drives patient satisfaction. Because what our patients want is everything. One of the studies by Scalhorn showed that patients after LASIK who had vision of 20/25, about 20%, 1/5 of the patients were not happy. So we need to target 20/20 vision. Post-op laser tuning or piggyback lenses. It may be intimidating thought for us to tell our patients to go in for another surgery, and we might be too busy cataract surgeons to do it, but this is what we should think. If we do not want to, there is still something at the horizon, that is the lenses which can be customized to patients' desires, patients' vision, and these are the light adjustable IOLs, which would be there for us. Pre-op measurements may not equate to post-op outcomes. This is because of finally how the implant wants to rest, and because of how the astigmatism shapes up because of healing. So these light adjustable lenses, after 3 weeks of post-op, we can laser change their power to suit what the patient wants. So these are the truly customized lenses, and they're almost there in the market for us. So do we have a lens which is advanced enough to be called premium? Probably or probably not. So what you choose is from a wide range. We have a wide range because we don't have the best one yet. What do surgeons, according to 1 or 2 surveys which I was looking up, how do they rank the premium features they want in a lens? Asphericity, which is there in all our monofocal lenses also, and toric design are the top things which they want, because they want to target the astigmatism, which is so disturbing to vision afterwards. Monofocal lenses are still our bread and butter. Most of surgeons, for most of their patients, want to do the monofocal lenses because of the ease of their use, ease of insertion. There are preloaded ones, slow unfolding. You can position them perfectly. There is consistency of results. You can sleep happily. There is reliable outcomes. Glistenings, reflections, any of the dysphotopsias are not there. And these lenses are really versatile. You can put them in the sulcus, God forbid. So these are some of the lenses which we are all commonly using. So we can now alleviate astigmatism, the suture, the surgically induced astigmatism, as well as the pre-existing astigmatism with our toric lenses. They are very, very stable, and the refractive predictability is high. They are easy to implant and rotate. However, sometimes some issues some surgeons do have with the translucent markings, and they may be best used with the is the 6 minutes up already?
Yes, ma'am. The time is up.
I'll just take 1 more minute, because we have a love-hate relationship with our presbyopic lenses. One of the things with the presbyopic lenses is the diamond eye light reflexes. I don't know how much you have experienced, but a lot of our patients, families come back to us and say that they don't like the sparkling of the eyes of their family members who have undergone these surgeries.
Okay.
Extended depth of focus lenses, they give us a good range of vision, and these are the lenses also a lot of our patients are more happy with, and the surgeons are happy also. But if you want the wow response, maybe you might want to go in for accommodative lenses. Monovision is what we have been practicing since long with our monofocal lenses, is still doing well, and a lot of our senior surgeons do swear by it, and they want to go in with a precise monovision. What is best to do is the dominant eye, make it plano for distance, and the other eye slightly myopic. You may mix and match lenses. You may use extended depth of focus in one and a multifocal in the other for the near vision as well as. Don't forget unpleasant financial surprises, because the cost factor is what you must discuss with your patient. Also, don't forget that sometimes, even though rarely, you might have to explant lenses or suture them because of perioperative conditions, or explant or in exchange lenses, which is very unpleasant indeed. Thank you so much. This is something I really liked, so I put it up for the last slide. Thank you very much.